So at ASCO 2020, we had a presentation of the highly anticipated CheckMate 9LA dataset. Again, this was a large randomized phase 3 trial for which we had an early press release showing that the trial had met the primary endpoint of overall survival. And in this study, patients without oncogene addiction, both EGFR and ALK, in the frontline setting with advanced non-small cell lung cancer were randomized to either histology-specific chemotherapy for 4 cycles or 4+ maintenance, or 2 cycles of chemotherapy plus Nivo-Ipi with the Nivo-Ipi Light schedule that we've seen before in CheckMate 227. Now, the trial met the primary endpoint of overall survival with a significant survival advantage for the 4-drug regime. And, this will ultimately, undoubtedly translate to a license, with the FDA and EMA. The question is really, where will it fit within our routine day-to-day clinical choice? The trial didn't show any particular predictive utility for PD-L1, so we didn't see that there was any difference in the 50% group PD-L1, the 1 to 49, or PD-L1 negatives. And of course, chemotherapy monotherapy is no longer our standard treatment. We are all giving either pembro monotherapy or pembro chemotherapy, and in the US they have a recent approval for Nivo-Ipi combination. So how this will fit in with what we've got is difficult to know, because actually if you look at the hazard ratio of the 4-drug combination against chemo, it's very similar to what we see with pembro chemo or even pembro mono therapy. One of the things perhaps we need to see is, as the trial matures, do we get a better hazard ratio coming through? Because we know from previous trials of Ipilimumab that this is associated with a much longer tail of the curve and much more durable survival than with single-agent PD-1, PD-L1 inhibitors. So, maybe we just need to see how this data matures to then better understand how we fit it into our practice.